This lesson will learn an inflammation of orbit, orbital cellulitis. Orbital cellulitis is an acute inflammation of orbital soft tissue, which belongs to the orbital specific inflammation. It divided into anterior orbital septal cellulitis and posterior orbital septal cellulitis, the latter also known as deep orbital cellulitis. Orbital cellulitis is the most common cause of ptosis in children. Immediate treatment is essential. Fortunately, the diagnosis usually is not difficult because the clinical findings are characteristic. Although most cases occur in children, aged and immunocompromised individuals may also be affected. Trauma may be the responsible for introduction of contained material into the orbital through the skin or paranasal sinus. In the pre-antibiotic era, orbital cellulitis frequently led to blindness or death, resulting from septic coronal sinus thrombus. The orbit is surrounded by the paranasal sinus, and part of their venous drainage is through the orbit. Most cases of orbital cellulitis arise from extension of sinusitis through the thin ample bones. The organisms usually responsible are those most frequently found in sinus, with many pathogens here. Clinical findings. It's most important to distinguish between pre-septal and orbital infections, both present with edema, erythema, hyperemia, pain, and leukocytosis. Chemosis, ptosis, limitation of eye movement, and reduction of vision indicate deep orbital involvement. Non-axial ptosis suggests an orbital abscess. Extension to the coronal sinus may cause bilateral involvement of coronal nerves 2 to 6, with severe edema and septic fever. Erosion of the orbital bones may cause brain abscess and meningitis. In children, few orbital diseases develop as rapidly as cellulitis. Confusion may exist with rhabdomyosarcoma, pseudotumor, and Graves' ophthalmopathy. Pre-septal cellulitis is the most common presentation. CT scan or MRI is helpful in distinguishing between pre-septal and post-septal involvement, as well as identifying and localization an orbital abscess or foreign body. Plain X-rays alone can only identify the presence of sinusitis. Treatment. Treatment should be initiated before the causative organism is identified. As soon as nasal, conjunctival, and blood cultures are obtained, intravenous antibiotics should be administered. In vitro antibiotic therapy should cover these 3 pathogens. Post-traumatic cellulitis, especially following animal bites, must be covered for gram-negative and gram-positive bacilli. Nasal decongestions and vasoconstrictions help drain the paranasal sinus. Early consultation with an otolaryngologist is helpful. Most cases respond promptly to antibiotics. Those that do not may require surgical drainage of the paranasal sinus. Early surgical drainage is indicated in suppurate pre-septal cellulitis. Okay, that's all for this lesson. Thank you. See you next time.